Yes, you can open the room, Lukan.
The room is opened already.
Lukan, should we all mute everything in order to be everything quiet, just the guy who is speaking to be unmute, or what?
We are on
Yes.
webinar setting, so only the panelists are able to speak and use their videos. All the attendees are mute by default. So,
Yeah. So I mean, because of the external noise or something like that, that's why I said.
no, I think we are okay with the sound now.
Okay.
We are on webinar setting, so only the panelists are able to speak and use their videos. All the attendees are muted by default. So, Gustavo, we are live now.
Okay, I like always to wait for 5 minutes to give people time to start because some have always struggled with connection. Then we start, as usual. We are Brazilian, you know, we always have 5 minutes.
Like Italians.
I think Italian it's a little bit more than 5.
You could be right.
I know.
Gustavo, we have an intro like a starter. So when you are give a go, I will share the screen.
Do you have the video from yesterday? That's the intro?
Yes, with the flyer for TVRS.
Okay, perfect.
Okay, and you don't move from there. Is that your bedroom?
No. No, this is the best place for broadcast, better internet, etc.
I know.
Lukan, I got an introduction with your flyer for the TVRS.
Yes.
And we discussed it with Hüning. We need a couple of minutes to make the introduction of TVRS to show why we do that.
Okay.
Is it okay?
Yeah. I will just put one flyer exactly on the thing. Just the second to handle the who can share. Okay. Now I wanted to put this one.
Okay. Okay. And that's give me a couple of minutes to discuss on that.
Exactly. This was the idea. Okay.
Okay. So I feel a bit like a host that did nothing about it. And Lukan and Hüning and Dzinic do everything because it's the young people faculty time now, and we have to grow back. And what is TVRS, first of all, for the audience that they listen? TVRS is Thessaloniki Vitrectomy Summer School, started 10 years ago to transfer knowledge in wet labs. And we do that every year, except this year that we postpone it for October 26 to 30 because of the coronavirus. And we don't want to stop connecting with each other. That's why we did this. And we're expecting just to show you a little presentation of how things are and where we are now. And this is the only way to come to Greece now. The way to come is just with a Sputnik or satellite or something like that. And this is where the meeting is taking place. Here is Thessaloniki, this is Turkey, this is Greece, this is Creta. So that's the only way to come. So if you don't want to come this way, we have to make it through internet. And next time we'll see you, it's going to be October in practical aspects and TVRS in Thessaloniki, which is a nice city, and people are coming frequently every year to train. We had a whole session for one day. It's a weekly meeting, and we have a session for one day that we teach how to treat cataract complications, especially IOL complications. And that's why we decided to do this. And we have the privilege of we were the first to use the Bionico artificial eyes, which is a great help to teach people how to do that. You see, we have an artificial eye with a drop nucleus, and people are training how to remove a drop nucleus from inside of the eye. And Andres Bernal from Miami, who is coming with us every year, and we do retinal detachment, we do cataract sessions, we do everything with his eyes, because these eyes are not destroyed. When you use them, you reuse them again, are reusable, because you just change the cornea, you just change, putting everything inside, you can inject the air, gas, whatever, and you can try, and it's a credible thing how true to reality are these. Our motto in Thessaloniki school is, before you start anything, learn how to finish it. And that's very important. You don't want to get stuck there. And of course, the best way to show you is what this nice video that Mrs. has done.
I can play it for you. Just stop it. I will play it for you.
It shows some places that we did this wet lab. We have a super nice wet lab. Everything is like material. We got the best of equipment for everything. Few people, only 30 people every year. And still, we even got a surgical SCP to train, and we'll try ILM removal with Bionico eyes. And that's about it. But I wanted to tell you what is TVRS and what we are doing. So from now on, it's your stage, and you can do whatever you like. I hope if you have any questions on that, I'll be happy to answer at the end. Thank you.
Perfect. Thank you, Athanasios.
Gustavo, let me play the video now.
Of course. Welcome everyone, wherever in the world where you are. Good morning, good afternoon, or good evening. This is the first TVRS webinar, and I would like to start presenting all our panelists from today. From Canada, good morning or good afternoon, my friend Mike Ahmed. How are you?
I'm good. I'm have your name though, so I'm a wannabe.
Biggest honor in my life, Ike. Thank you so much. Second, bonsoir France. How are you, my friend Didier?
Perfect, perfect. And thank you for your friends.
Thank you. I'm making an effort. Buonasera, Italia. Carlo Carlevale, our keynote speaker, and Matteo Forlini. Come andiamo. How are you?
Fine, thank you, Gustavo. Thank you. I'm proud to be here with all of you. Thank you.
Buonasera, buonasera, and thank you for invitation.
Dobro večer, Serbia. How are you, my brother Vladislav Dzinic?
Dobro večer, my friend. Fine, thank you. Congrats for the nice organization. Thank you.
Thank you for being with us. Our professor and our dean of this webinar, Kalispera Elada. How are you, Professor Athanasios?
Είμαι πάρα πολύ καλά, το ίδιο ελπίζω και εσείς. I'm just using, these are Greek to you, of course.
Ευχαριστώ.
Παρακαλώ. Just one question, because I'm illiterate with the computer. I don't have I don't see what you're doing. I just see your faces, but I don't see the presentation that Mishev showed before. I couldn't see the screen. Is it something that I ought to do, or just I can see your faces, I can talk to you, but Mishev was presenting a video that I couldn't see before. I'd like to see your presentation also. So when you start, just tell me. Don't mute me.
We'll let you know. We'll let you know. Don't worry. Okay?
Thank you.
Last but not least, my brother and organizing of this webinar, Dobar den, Bulgaria. How are you, Lukan Mishev?
Bom dia, Brazil. Everything is fine here.
Finally, you learned it. Thank you so much. And last but not least as well, boa tarde, Brazil. Thank you for being with us. I don't want to waste the time of our attendees. The first speaker will be my good friend Matteo Forlini. Forlini, the screen is totally yours.
So, okay. Perfect. So, I'm talking about my solution is artificial, about Iris Claw IOL. So we know these are the scenario, and we know that iris fixated IOL can be two types: sutured iris fixation IOL and iris claw fixation IOL. Of course, indication is absence of capsule support, but we have to remember contraindication could be significant disruption of anterior segment from congenital anomalies or traumatic damages or multiple iridectomies or congenital aneurysm. Two types: sutured iris fixation and iris claw fixation, anterior claw and posterior claw. Today, I'm talking about iris claw fixation. So we have to remember the surgical technique: corneal opening at 5.5 millimeters and two small paracenteses. It's important to administer a meiotic agent to maximize iris tissue exposure and viscoelastic to minimize trauma to the corneal endothelium. Then we rotate, and we know that it fixated to the iris without the use of the sutures. So the enclavation is it means a small bunch of iris tissue drawn inside each of the two claws and captured. You can see in the video the very good detail of the enclavation, and this is the anterior enclavation. And later we'll see the posterior enclavation. At the end, we do a peripheral iridectomy, but only for the anterior enclavation. In our experience, we never do peripheral iridectomy for the posterior enclavation because there is space for the aqueous humor to pass. And then at the end, of course, the corneal suturing. So we have to remember that for anterior chamber iris claw, the constant is 115. But if we want to implant the iris claw on the posterior surface of the iris, we have to rotate the IOL, so upside down,
because the vaulting is different, of course, and the constant will become 116.5, almost 116.8. Very important to remember. So, clinical case. This is a subluxated IOL, and you can see that subluxated IOL is removed from the superior sector after corneal opening, about 5.5 millimeter, I repeat. And after IOL removal, we perform anterior vitrectomy, of course. We check the vitreous, and then we are ready for the anterior iris claw IOL enclavation. So we filled the viscoelastic in the anterior chamber, and holding the iris claw with the one hand, we are performing the enclavation with the other hand. So one side and then the other side. It's very important to hold the lens very strongly to obtain a good enclavation. Then centration, we have to create a good centration on the pupil, and then the final peripheral iridectomy. I repeat, we perform peripheral iridectomy only for anterior iris claw. I show you a second case. This is another case of subluxated IOL, but this time we are doing the posterior iris claw enclavation. So you can see in the video, first we remove the subluxated IOL from the posterior chamber into the anterior chamber. And then we open the cornea and we remove the IOL. This was a 3 pieces IOL subluxated. And we are performing the iris claw enclavation on the posterior surface of the iris. And the procedure is very fast. You have to hold the lens very strongly, and the centration is very important. So you have to be very careful to obtain a very centered IOL enclavation. Then these are some steps of the pars-plana vitrectomy. In this case, we also perform the pars-plana vitrectomy because the patient had developed some vitreitis or inflammation caused by the subluxation of the IOL that was hitting the ciliary bodies. So this is a classic vitrectomy, and this is peripheral shaving with illuminated indentation from ab externo indentation. And this is the final result. So you can see, you can have a very round pupil, and usually we suture the cornea. Usually we put just 3 corneal stitches to close the corneal wound, and no peripheral iridectomy when we do the posterior iris claw. So take home message, iris claw IOL, many advantages. It's fast surgical procedure. You can avoid conjunctival opening if you want to create a corneal wound, or you can do a sclerocorneal tunnel, but you have to open conjunctiva. And iris claw is fixated to the iris mid-periphery, and that means a minimal effect of the normal physiology of the iris or anterior chamber angle, and lower incidence of corneal decompensation, secondary glaucoma, and cystoid macular edema. These advantages for some surgeons can be a complex surgical technique. Actually, I think it's not so complex, but of course you have to be very careful in some steps. And one other disadvantages are astigmatism, because you have to open at 5.5 millimeter, because we know that iris claw IOL is rigid, so you have to open a lot, 5.5 millimeters. And you can have a pupil distortion if you are not good in the enclavation, but maybe I can tell you later some tips and tricks to avoid pupil distortion. So this is it. I just remember you again, the 10 TVRS course, 26th, 30 October this year in Thessaloniki, like every year. And thank you for your attention.
Nice, congratulations, Matteo. Very good, very good.
Thank you.
We have a question from the audience, from a friend, Mortazavi Fart. Do you prefer horizontal or vertical enclavation, and why?
Well, actually, I prefer horizontal enclavation. The reason why is very practical, because usually I sit at 12 o'clock like in the classic situation of a vitreoretinal surgery. So sitting at 12 o'clock, I open the cornea at 12 o'clock, and it's much easier to perform enclavation horizontally. But in some cases, I did iris claw enclavation in severe traumatized cases, and sometimes you can have iris tissue damaged. So in some cases, I could not find a good iris tissue at 3 and 9 o'clock. So I put myself on temporal, and I did the vertical at 12 at 6 o'clock. And I noticed no difference. Actually, there is not a rule. Just you have to be comfortable, and you have to be in a comfortable positioning with your hands, actually.
Okay, perfect. We have another question. What about iris atrophy secondary to iris claw?
What about, excuse me?
Iris atrophy.
Oh, well, the iris claw, if you do a good enclavation, you don't cause big iris atrophy. Because it's very important to be fast and delicate. Of course, if you do many attempts of enclavation because you don't see a good, so you try, that is a mistake because you can ruin the iris tissue. That's why it's very important to stay calm, to obtain a good centration with your dominant hand, holding the lens, and then just one maneuver. If you do small maneuver, you don't create atrophy of the iris.
Excellent. Any other of our panelists have some experience with Artisan IOLs, please?
Yeah, Gustavo, I really like the Artisan lens. Of course, we wish it was foldable, but in the 8 technique powers, it is not currently. My preference actually is I sit temporally, and I use forceps to hold the lens and to enclavate the iris. I think that's another alternative, although the needle, as Matteo showed, is a very nice procedure as well, or the vacuum fix. But I find that the forceps, microforceps, are easier to grab the iris. Sometimes the iris is concave or is a little bit friable and thick, so the forceps do a reasonable job as well. So it's another alternative to do it as well, and I think either approach is reasonable. But I think it's a very, very useful lens for these cases.
I agree, Ike. I agree. Actually, in my experience, I feel more comfortable with the posterior iris claw enclavation because, as you said, when I do anterior iris claw enclavation, it's not easy sometimes with the needle to catch the iris. So microforceps for anterior enclavation can be very helpful. Yes.
Okay, and the last question before we move ahead, when do you do anterior and when you do posterior enclavation, and why?
Well, as I just said, I usually prefer posterior enclavation. So if I can choose, always posterior. Why? Because I prefer posterior since I think it's more physiological, the IOL positioning under the iris. Also for aesthetic reason, because the patient, if you put the IOL behind the iris, the patient cannot see it. So it's not a prosthesis looking at the mirror, for example, or the other people don't see it. Mm-hmm. Otherwise, in the anterior chamber, you can have some glistening and people can see it. And also, as I just said, I think it's even faster and easier for me to do the posterior enclavation instead of anterior enclavation. But this is my personal experience, of course.
Okay,
as a vitreoretinal surgeon, I feel comfortable in this way. But for anterior surgeons, I know it can be easier, the anterior enclavation. Didier?
Yes, last advantage to put it posterior is that if there is a detachment, if you put it anterior, you cannot inject gas. If you put it posterior, you can inject gas.
Yeah, because you have a diaphragm. Yes.
Yeah.
Okay. Very last one, because this one is important. How do you calculate the power of the Artisan lens?
Yeah, I said before in a slide. Okay, the power is different because when you have the box of the IOL Artisan, it's written constant 115, and this is the constant for anterior enclavation, the anterior chamber. But if you want to put posteriorly, you have to calculate constant 116.5. So you have to add 1.5 more than anterior chamber. So 115 anterior, 116.5 posterior.
Okay, perfect. Thank you. We have to respect the schedule. Our next speaker, he doesn't need an introduction. My friend Gustavo Hüning, more known as Ahmed, please go ahead. You are muted, Ike.
Sorry about that. My house is always crazy, so I want to make sure I don't have any unusual sounds that come to you. It's a pleasure to be here, Athanasios and TVRS. I haven't been to your meeting, but I'm happy to be here for the first time virtually. Thank you, of course, Gustavo and Lukan, for all the things you do to put these media together, make it interesting, and I'm always looking forward to your trailers as well. And thank you to the rest of the world who are watching here. I'm making a lot of new friends, which is wonderful. And the people here, some of them I know, some of them are new, and I'm looking forward to the presentation. So my topic is, I think everybody knows who Humpty Dumpty is or was. And Humpty Dumpty, of course, had a fall, and we have to put him back together again. So that's what my presentation is about. This first case, I have two cases to share with you, and I'm glad that Matteo started because he spoke about the iris. And I will speak about this as well with refixating lenses to the iris. This patient has a 3-piece hydrophobic acrylic in the sulcus. You can see that it's subluxed. Patient had a previous AC IOL actually, had a lens exchange for this lens. The sulcus was thought to be stable, but it wasn't, and you can see the lens is subluxed in the sulcus position. To me, these are ideal lenses to reposition to the iris. They are out of the bag. They are 3-piece lenses. They are 10 degrees vaulted. We have had very good success with posterior iris IOL fixation for these cases. Some of the tips I'd like to just share with you is to use some myostat to bring the eye down, the pupil down, to create a cat's eye appearance once we trap the optic through the pupil. Place the incisions so we can use the CIF4 needle. It's a tenoproline suture, and pass the curved needle through the iris, under the haptic, and through the iris again. Try to take a small bite and try to do it in the mid-periphery of the iris, not too close to the pupil and not too far into the angle to make it difficult to access. Once we pass it all the way through, it helps to have a docking needle to do this, and then there are a variety of ways that we can use to suture. Here I'm using a couple of specially designed micro tying forceps to tie suture in the eye. There are a variety of ways, mechanical, intraocular tying like this, or modifications like that we'll show as well that we can use. Don't lock the knot yet, just tie it snugly and continue to suture the remaining haptic. It helps, of course, to see the haptic outline during the pass, as we showed earlier, and the suture will secure it to the posterior iris. Here we're using a modification of mechanical. It's been called the Ahmed. Maybe we'll call it the Gustavo, perhaps, as well. And we take the microforceps and we slide the suture into the eye. This is a fairly easier procedure to do, perhaps, than tying in the eye. But we haven't locked the suture yet. We prolapse the optic again behind the iris, and you see the pupil is a little ovalized, which is not surprising because the iris is imbricated within the knot. And so it helps to first free it up by taking a pair of forceps and pulling the iris centrally from the knot while pulling the suture externally to release the iris from the knot. Of course, we want the haptic to remain there, so don't be excessive in terms of the traction. And we now have the pupil that is nice and round. We will then lock the sutures, as we'll show, by again, first of all, cinching it down, tightening it again, now that the iris has been free, and then using a locking knot to secure the knot. I typically like to do a 3-1-1 suture, as we're showing here, to do this. And again, whether we're comfortable using intraocular tying, like Ahmed, seeps or sliding knots, or even the classical mechanical, these all can be used in this nature. And so I do think this is an underutilized technique and a micro scissor to cut. I think we've all moved towards sclera fixation, which is very nice. But the advantage here is we have no externalized haptics. We have not opened the conjunctiva. We have minimizing the issues of tilt. And we have fixation on the iris by suspension. And the 10-degree vault is well tolerated. As long as the lens isn't tilted, we're in good position. You can see the sutures present here postoperatively. The pupil is nice and round. The eye is quiet. The UBM shows the lens position, and in fact, these lenses, in my opinion, are less likely to cause problems than sulcus lenses because they're not moving and they're in relative distance from the iris constantly with a 10-degree vault. The IOL calculations are really similar to what we showed for in the bag, and you can see the pupil can be dilated fairly well. So that's iris fixation, and we have published on this. We typically use micro-instrumentation, especially designed micro-tying forceps, and tonoproline suture to do this as well. My next case is a little bit sad. You'll see here, I'm playing a song from Celine. Can we get the... is sitting there with one zonule all by herself. And our goal is to try to refixate these lenses. And I like to use a slow fixation technique that many have published, including our group many years ago, where we use an over-under approach to lasso the suture. As opposed to iris, I think Gore-Tex is a preferred option to minimize suture breakage. The needle is not as amenable to work with. However, the material is excellent in terms of durability. This patient here, you can see, had a subluxation many years prior to presentation, but refused surgery, and is a monocular patient, refused surgery, and eventually the patient ended up basically having a completely dropped lens. The patient also, you can notice, has RK, also has a small pupil, and as you can see, the 16 cut RK. So I was not very enthusiastic about making anything specific on the cornea, any kind of large incision. These patients, of course, require vitrectomy. We typically do 4 ports here for good access as needed, 3 or 4 ports, I should mention. And we first, of course, have to manage the vitreous in the vicinity. You can see the lens is subluxed. It's actually hinging, barely there on the peripheral zonule. And we will perform vitrectomy, of course, to ensure that we have cleared the area of vitreous to ensure that when we levitate the lens, we'll be able to do this without traction. The lens here we may consider perhaps to be not usable, but it's still, the lens actually is fine. It's just the attachments aren't very good. And so we're going to reattach. Now, this is a bit of a tricky part here. We are using aspiration on our vitrector cannula to bring the lens up by aspirating on the anterior capsule, switching to a pair of forceps through the corneal incision to bring it up and levitate it anteriorly. At this point, the very strategically placed iris hooks are used to secure the capsule Rhexis. The capsule Rhexis is a wonderful place to secure lenses, whether they're crystalline lenses in Marfans or pseudofoliation, or in this case, we have a sublux lens. This patient actually has a CTR as well. We're making a scleral groove here. This should be about 1.5 millimeters behind the blue zone, or approximately 2.5 behind the limbus, to ensure we don't make it too anterior. This is actually a circumferential pass. A 25 gauge needle is used to paste to the sclera, enter to the posterior capsular bag, to the anterior capsule in the vicinity of the haptic optic junction. This will be the underpass of the Gore-Tex suture. I like to use the docking approach like this. The control of a hypodermic needle is quite useful here. And we have our pass here. This is a double-armed Gore-Tex suture. Some people use ninoproline. I think that's okay and reasonable for older patients. But for younger patients, we do like to use Gore-Tex here. This is 7.0 Gore-Tex. We now have made our pass. We can then basically do a slip knot to secure the haptic and the capsular bag. However, I don't typically lock it. Notice in this case, we made the first pass, in this case here inferiorly, in this case. And we're going to do the same thing, but opposite on the other side, meaning that the underpass here is made superiorly. So therefore, we avoid any torquing of the lens because the sutures are being placed horizontally rather than vertically, although vertical perpendicular pass can be also made. There's the first pass underneath. You can see we're passing underneath the haptic and the CTR. And we have a second pass made. We will tie our sutures and titrate the tension. This is important, not to tie it too tight, just enough to make sure that the IOL is well centered, and then we will lock the knot. It's important for Gore-Tex to bury the knots. And we've made a groove, of course, for the sutures to fit within, but we have to bury the knot by pushing the larger size knot into the sclerotomy that was made, and we have concluded the case. And so that is a reasonable approach for refixating in the bag lenses. It doesn't involve an exchange. We keep the IOL in the bag. It can be used for 3-piece or 1-piece lenses. Thank you very much, and it's a pleasure being here again.
Ike, Excellent. Let me add a great person here to this discussion. He sent you a question, but I'll add him to the discussion. 1 second. Let me find this gentleman because he is amazing. I'm a great fan of him. Let me find here. Promote to panelist. Okay, Carlos Matteo. Can you hear us? You are in the discussion?
Yes, yes, of course.
Hey, Carlos.
Hello? Now, yes. No?
Hi.
Unmute? Now.
Hello. Hi, Carlos.
You know, it's-
1 second. We cannot listen to you, Carlos. 1 second.
Yes,
Unmute.
now?
No, not yet.
Can you hear me?
I can hear you. That's perfect. Yeah.
Okay.
Huge fan of this group. Yeah, hi.
Welcome, welcome, Carlos Mateo. Thanks for being with us.
Thank you very much. I have 2 questions because I love, suture to the iris. I love it. But they have some cases with 3-piece lenses that they reluxate. Many months later, only one of these haptics. Have you any explanation of that? And the second question is, in 1-piece lenses, you suture to the iris, or because I suture and as you said, no problems, and it's a great technique for vitreoretinal surgeons that we are. These are the 2 questions.
So thanks, Carlos. I mean, great observations. In terms of suturing the 1-piece lens, I'm not a big fan of suturing to the iris because the lenses are planar. They're not vaulted. They're bigger haptics, and there's a potential risk, a higher risk, I should say, of potentially getting pigment chafing or UG syndrome, theoretically. So I don't typically do this. And I should also mention that I don't suture in the bag lenses of any kind to the iris. I think that the iridocapsular adhesions and the somerings can be a problem. Now, your first question is important as well. And I think a couple of points. First of all, Prolene suture can degrade. It can break. It can break by chafing, not usually in these cases because the suture is around the haptic in the iris, but also UV light can also potentially degrade it. We don't find it very common, but it theoretically can happen, but usually it happens over many years. The other possibility, of course, is that the suture passes are made too peripheral. So I like to make the suture pass relatively closer to the haptic-optic junction, maybe about 1/3 or so, or 1/2 from the haptic-optic junction. I think if we do a secure knot, I find it really very low risk it'll re-sublux in our experience. And so that's been our experience with it. I think, the only reason why it was sublux, if the suture was not adequately tied or if it was rotating around. And it just hasn't been our experience. In fact, usually what we find is, in the rare cases we go back, that the haptic actually can be fibrosed to the iris in some ways. So this has been our experience. But any of these cases, of course, we always have concerns about rotation, breakage, all kinds of things that can happen.
Great. And that's more strict, I would say, for Lincoln zeros. I know what Lukan is going to say. Please, Lukan, tell us about the article you found this week about Berlin.
Yes, there is an article published claiming that after 14 years, Prolene sutures doesn't degrade. And I agree with Ike that probably for late subluxations, probably the knot was not well tightened or something is wrong with the suturing. I want to make a comment about the single piece IOLs. I also like to suture IOLs to the iris with the Sutures sliding knot because I think it is a good escape maneuver when you don't have backup lens or something like that. Actually, I think that hydrophilic single piece IOLs are not so sharp in their edges, and in my practice I haven't seen any UG syndrome or chafing or pigment dispersion. I do have my concerns about hydrophobic single piece IOLs because they are not vaulted and the material is more tough and the edges are more sharp. With that said, I would suture a 3-piece lens to the iris with no hesitation, but for single piece IOLs, it's a borderline condition. Depends on the situation, actually.
Very good. Another question, people want to know if you always do a peripheric iridotomy in these cases when the IOL is too close from the pupil.
It's a great question, and I'm going to recommend that even for scleral fixated lenses, a PI should be considered and done because these patients can get reverse pupil block and UG syndrome or pupil capture. These are vitrectomized eyes, they're deeper ACs, the iris may not be full consistency, and so I think it's a reasonable thing to do. Often they have PIs already, but I think it's a good idea to do that to prevent the reverse pupil block, and that can cause, you know, pigment dispersion, UGH, hyphemas, and pupil block and capture. So I think it's a good idea to do that.
Really, really good. Ike, thank you so much. Carlos, stay with us, please. Our next speaker, our dean, our big boss and professor, Athanasios. Go ahead. The screen is yours.
Oh, thank you. And and now I have a little bit of track because Carlos is there, and he's always opposing to whatever I will say. So it's a 20-year thing going on. And also, Ike is, I'm very good fan of Ike, and I look at him, but I have a bit of a trouble. And that my trouble is that I don't have the chip in my brain for suturing things inside the eye. You need to have a special chip for that. Some people play good tennis, some people cannot even hold the racket, some people do skiing, but they don't. Tarek Hassan used to tell me that if you don't have the chip, don't try it. So I'm always confused when I suture inside out, and I don't know which end I should suture and whatever. And it's not dexterity of the hands, it's dexterity of the mind. Some people have the ability to suture things. Whenever I tried to suture many years ago, I had tilting problems, actually. So this time I'm trying to do my way, which is I'm going to show you a few cases that I'm always on a training program, and that means I have multiple cases of let me see, of dropped nucleus and drop lenses and everything, because I got a lot of these conditions in a training system. So let me start the presentation. We got some aspects to tell the people that we always have to train them this way, and I'm using always a bimanual chandelier light in order to have two hands. When you do reposition, you need two hands for my idea. Also, you need a wide angle, but non-contact lens, because you don't like something to touch the cornea while you go up and down. And it's very important for me. So our basic steps is first, to do a complete vitrectomy. The vitreous plays a very important role if you leave anything. The second thing is, when you try, my fellows and me, when
Athanasios, sorry, we are not seeing your screen.
You're not seeing my screen?
No, please share it.
Let me see what I can do for it.
Take your time.
How I can't see anything, and I have to go back here, and I have just the faces. I don't have anything else in my screen, and I don't have even the Skype to put it my screen inside. I just have your faces only.
Okay, down you see the green button, share screen?
No, I don't see the green button. That's what I mean. I don't see any green button anywhere.
Let me see.
Miniaturize.
You're probably in PowerPoint, so you should go out of PowerPoint first.
Okay.
Yeah, so escape and go to PowerPoint, and then click the Zoom app.
Let me PowerPoint to go away. Okay, I went and go to
Zoom.
Zoom. No, it get me. Zoom is lightweight and useful. He get me into the. Is it possible for somebody else to continue? I don't want to lose any time of your time, and I'll try with Hüning to fix that.
Of course, take your time. So our next speaker would be Lukan. Can you do it, please?
Yes. Just a second. So, can you see my screen?
Very well.
Yeah. So this is a case when I created a posterior capsule rupture. I tried to save the epinucleus, but unfortunately the Titanic maneuver was already there. Then I tried to clean with the vitrector in vacuum only mode the remnant cortex, and the good thing is that I have a good anterior rhexis. Now I like to clean the vitreous before reaching out and cleaning the fallen epinucleus in order to prevent inducing of any breaks by tractions. Then with 23 gauge cutter I will easily remove the epinuclear material because it is soft. I like to use my light pipe as a chopper or adjunctive device to press the material to the opening of the vitrector. I don't like to use PFCL for soft remnants of the lens. Probably if it was a nucleus I would use a PFCL. Here is a playing between vacuum only and vacuum and cutting in order to engage the nuclear pieces and to eat them. I use high vacuum settings like 600 vacuum, and I reduce the cutting to 3000 in order to have the port more open to eat the epinucleus. And when I am done with cleaning of the posterior pole, I will try to find my solution for intraocular lens. So this eye is a little bit myopic, and the lens, as I remember, is out of the normal range that we can keep in stock in our operating room. And normally in such situation where we have a well-preserved anterior rhexis, we are used to implant 3-piece lenses. So a quick decision was made to implant the intended hydrophilic single-piece IOL and to fixate the IOL to the anterior rhexis. Now, when I implant the lens, I stop the infusion, then I will re-engage the infusion in order to keep the anterior chamber filled with the OVD. Now I will go with microforceps and micro scissor and will cut part of the haptics in order to achieve the optic capture with these haptics. When you cut the inner foot of the haptic, you will actually have a good locking plane on your remnant haptic. Now I will put the optic behind the anterior rhexis and we will leave the haptics above the anterior rhexis. Probably you can do it with any instruments, as I do it here with Sinski hook, but probably with micro graspers it will be more controllable. But still it's a situation of improvisation now. So this haptic will go over the anterior rhexis, and this is a myopic eye, so no issue I find with the shallow AC or some contact with the haptics with the iris, and the lens will be fixated to the anterior Rhexis, and centration and absence of movement could be achieved. So this is the capture. Then with the vitrector I will open the posterior capsule a little bit more in order to provide clear optical path and to be sure that there is no incarcerated vitreous. I don't like to put mile-hole or any other things in anterior chamber. I like to use mechanical stretching of the iris in order to bring the pupil back. And with a little bit pulling, the pupil constricts fairly well. And actually this is the end of the case, and the IOL is perfectly fixated. This is my case. Thank you.
Bravo, Lukan. Amazing. Tell me, how did you have the idea? I'm really curious about it.
Same way as your idea with manometer and anesthesiology machine when you needed to use for fluid air exchange. When you're in the angle and you don't have choice, you need to improvise, and sometimes good ideas are turned to reality. So it worked for me. I found that it can be fixed like that, and there was no issues later with this lens.
Okay, you didn't have any iris syndrome or something like that?
No, as I said, this is myopic eye, so the AC is deep, there is enough space, and this is actually iris fixated IOL like Femtis or 90S, this photopsia lens from Professor Musket. Is the same principle actually.
Nice. And we have a question. Why you didn't use PFO for the soft lens pieces in the back of the eye?
Because I'm fairly confident in my control of the vitrector, and this material cannot cause any damage to the macula.
Perfect. Didier, do you want to ask something to Lukan or any comments on the technique?
No. I'm very happy to see what Luca presented in slowing down the cutting speed and increasing the vacuum. So this is the way to remove a lot of nucleus. Yes, perfect.
Thank you, Didier.
Very good. Another question for you, Lukan. Why you didn't reverse the optic capture?
Actually, I thought about that, but these haptics are fairly huge, and I was worried if I can damage the capsule structure, and I chose the easiest way to capture the optic and leave the haptics in front.
And the other thing, let me see from Chen Malay. I want to know if the IOL hydrophilic or is hydrophilic or hydrophobic.
Hydrophilic lens from BNL.
Okay, and last question, Lukan. How do you remove the OVD?
You can remove it with INA, of course, but there is a way to wash it out with cannula through the main incision, which is, I believe, more easy and more safe to do that.
Very, very good, my friend. This is a good one. How exactly do you cut, where exactly do you cut the haptic? There is any place? Do you measure? How is it? What's the, besides the improvisation, how is the technical part?
In this particular design, you cut the inner foot or leg of the haptic in order to achieve classical optic capture like three-piece lens. So you just cut it, there is no particular length of the foot.
Thank you, Lukan. I always envy the quality of your videos because they're amazing. I feel ashamed when I show mine. Okay? Athanasios, how are we?
Yeah, I hope I'm good because I can see you now, and I'm just trying to project the PowerPoint again.
Okay.
See if you can see it.
Now, let's type share screen and then choose the PowerPoint window.
Click, sir. On share screen first.
I have the share screen here. Okay. And I have two screens now.
Now you choose PowerPoint. Bravo. Now we have you. Go ahead.
Okay. I have a stick here, and I'm choosing the PowerPoint. And can you see it now?
Yes.
Perfect. Yes.
Just make it full screen.
Make it a full screen. Okay.
Perfect.
So I'm going back to say bimanual, wide angle, and then first you need a complete vitrectomy, as Mishev and everybody else said. And one issue that I try to think about all the time is how to test the IOL if it's sitting on the retina. Once at the TBRS, Riemann showed us how to use the fluid backflash active section to lift the lens, and then you can grasp it with the other forces. So this way you're not pressing against the retina, and it's a very good idea. I used to use the hold of the body, avoiding to grasp the haptics, because sometimes you can bend the haptics and you can destroy the lens, because I would like to use the same lens to put it back in any position that I would find comfortable. And I'm using both forceps to pull the intraocular lens every time into the anterior chamber. Whatever I want to do, I want to put the lens in the anterior chamber first, then to follow up to clean the posterior vitreous of whatever I need to do, and then to put it in a position, either it's going to be endosclera or it's going to be in the sulcus or wherever I want to be. And the issues that I need to remember is bimanual vitrectomy, suction lifting, body grasping, handshake technique. The handshake technique is very important to learn because it gives from one piece to the other, and I try to teach people how to do that because it's very comfortable, and you need to know this technique in order to do an endoscleral lens in the right way. But if the drop lens is damaged, you need to exchange it. It's mandatory. You don't need any bent haptics to stay in the eye again, because then you have tilting, which is very, very ugly. And I would like to share some cases and tips and tricks that I'm doing here. And here we got a guy was complaining about everything, and we didn't know why was that. And then we show that the Acrysoft has been put into the eye with the inferior haptic completely turned around when he was injecting. When he was injecting, he forgot to turn it, and you can, with those flexible Acrysoft lenses, you can stay in the sulcus also with a very bad haptic. So we need to change the haptic. And another surprise that I had was we had a dropped lens completely with the sulcus and all the membranes around it, and we tried to grasp it using both hands. And as usually, I tried to pull it from the anterior chamber, and while I'm holding it, I tried to open up because it was completely destroyed. And then I found out that we had a ring, capsular ring, that I took out, and I thought that was it. And then I removed the lens together with a sack, and I found out that there was another ring. So that's the first time I removed two capsular rings from one eye, and then you can use them. You can use the lens, the capsular rings, if you want to use them again. But that was really how he put two rings and then put a soft 4-piece lens in the sulcus. How can you do that? But a lot of things are happening. The other thing is, if you have a lens and you don't want to cut it, or you cannot cut it, you can use the 6 o'clock method. You can put from 6 o'clock a fluid needle inside from the 6 o'clock, and then grasp it from the 12 o'clock, fold it, and take it out from a small space, 3 millimeters opening. So if you want to exchange, that's another idea we have. And that's the ordinary thing that we usually do when we have lens that is inside, and it's a three-piece lens that is floating in the surface of the retina. So we've always tried to remove all the vitreous we can, and then we're using the bimanual technique because we have the light and we have two forceps to do that. And we hold it with one hand vertically to go upstairs at the anterior chamber, and then we use the other hand to push it gently, and we call it reverse dialing. When you go into the anterior chamber, you do a reverse dialing in order to have one piece in the position, and you grasp the other piece and you turn it around until you put it in the anterior chamber where you have it. Here you have a piece of the capsule engaged that we saw it when we just put it in the anterior chamber. What is the why we do that? Because sometimes you need to do things. You need to clear the nucleus, and you need to do things like that in the back of the eye, like here. But if you have the lens taken out or put in place, then you cannot see very well what you're doing, and you don't want to work in an open space or an open eye. So you want to have the eye closed as possible, put it in the anterior chamber, and then you decide what to do. Sometimes things are not so easy as you saw before. It can become harder and harder all the time. And here you can see that you have a lens and the nucleus together in the back of the eye. So how to remove both of them, and I'm going to show you that we try to remove it by forceps and by vitrectomy, but it doesn't work. And we thought that it was very hard, so we had to use endophaco fragmentation. And we saw a technique, because endophaco fragmentation can be very dangerous if you don't use both hands. Because with two hands, you can actually guide whatever you're doing, and you control suction in order to keep the nucleus in a safe position and treat it slowly, and don't let it open at all, because if you let it open, you have a 90 gauge suction to a 25 gauge infusion, so you can have a choroid collapse. So you need to be, and then we go for the flute needle to remove the lens, which is a three-piece lens or a two-piece, no, it's a single piece, and we take it out from the eye. So these are and take it to the anterior chamber and take it out. Of course, in these conditions, we don't like to have, it can be worse. We call this case no fishing example. People, when they drop something inside the eye, they tend to go to grasp it and take it out again. And look what happened when you try to do fishing of the nucleus. You got a PVR with huge holes and some pieces of nucleus everywhere, even behind the retina. So this is to avoid, to tell people, take home message, if you drop something, don't go fishing for this in behind the iris. This can be the result. Of course, you don't think that it can be anything worse than that. This is another tip. If you like to have a chandelier light that you need to guide the light, you can have a steady strip around it so you can let the assistant guide it. And here you have a PVR with a lens, and it's supposed to be inoperable because the lens is sitting on the PVR. We cannot say no, we have to do it, and we try to remove the lenses, and you see how the eye was bad. Another tip is, before you use both forceps, you have to open them to see, because these forceps from the company, sometimes they don't open the same way, both of them. One of them is smaller than the other, so you cannot grasp the body of the lens sometimes. So before you cut something inside the eye, test it outside to see if the opening is sufficient enough. And then we remove that. And then we went out for the PVR to show you that you should never say impossible, and that's the end of the operation while removing the perfluorocarbon and injecting silicone oil. So things can happen, and things can be very tough. And the position that you use is Sulcus, Iris, and the Sclera, and the famous Carlevale lens that we want to use, but we didn't have it. And I think it's going to be my next choice. And if I have something to do, I do the easy endosclera that I call for everybody, because that's the easiest way, 180 degrees. And then this is the result. This is the UBM. And this is the training we need to do in order to learn people how to do it with a 3D stereo and going to the TVRS, where you have one-to-one sessions. And next thing is going to be in October. I hope it's going to be without any coronavirus hanging around us. So thank you very much, and I'm expecting any questions from now on. Thank you for coming. You've been great people everywhere.
Very good, Athanasios. Really, really good. I can stop your screen sharing from here. Thank you so much. We have an interesting question here. If you have ever thought to use a finesse loop to pick up the IOL by looping the haptic, what do you think about it?
It's a great idea, because it's just but do you know how much is a finesse loop 25 gauge? How much it costs?
In Brazil, we don't have it, so I'm not worried.
So it's a kind of a lasso thing that you can remove foreign bodies also. And there's a lady in Turkey who just was holding the nucleus while eating it with this kind of things, holding pieces of the eye. Yes, it's a good idea. And I think they should make something that it can hold haptics and take them out. But why to do that if your suction is enough? I think Ike showed that he can suction with a probe, the lens. But the point is, don't get against the retina. Don't push anything against the retina. Lift it in the middle and then use whatever you want to do.
That remember me something, a video I saw like 5 years ago. They used a urology instrument to get kidney stones in the urethra, and then you grab the nucleus and you can eat it, holding it in the middle of the eye. It works perfectly because that probe is 23 gauge. It works perfectly. I can share later the video. I'll look for it, because the idea was genius stuff. Didier Ducournau, I have a question for you from YouTube. Which is the specific technique to induce posterior vitreous detachment? Because one thing, we have lots of young people here, do not touch anything before you do the vitrectomy, or you're going to have retinal tears. Please tell us about it.
So my trick is the following. I make the posterior vitrectomy, but I leave 2 to 3 millimeters. I don't hit the vitreous in the 2 to 3 last millimeters close to the retina. So I leave a kind of mattress adherent to the retina. And then when I have done a gap, I go down, stop cutting, and aspirate. So the fibers enter the port, make an occlusion, and the vacuum raise up to 650. And then you can catch the posterior haloid and bring it in the lacuna, and you eat the vitreous. It takes something like 20 seconds.
Very good. Carlos, Matteo, would you like to add something?
Yeah,
Athanasios,
in the case of the aqueous lens, because in US there are many surgeons using the aqueous lens, this is the hydrophilic lens, to make exchange and to use the Gore-Tex to suture in 4 points. Have you ever considered to, in your case of aqueous lens, to use Gore-Tex to suture to the sclera, or you remove all of these aqueous lens up?
I don't suture these lenses because I had a couple of bad experiences, probably, as I told you in the beginning, because everybody is doing well and I didn't, probably because I don't have it. It's not in my way of doing correct things with suture lenses. I do mistakes, and I got a couple of tilting problems. And then remember, if you have a problem with the suture lens, then you have to go back in the eye, and the patient is very unhappy if you want to fix it. So you have to be very, very eye-key in order to do it correctly, and I'm not.
Carlo Carlevale, if you didn't have the Carlevale lens, what would you do in this case?
I don't know. Basically, I mean, I don't like Gore-Tex suture anyway. I don't like suture at the moment. So, I mean, it's better, I can't tell you my opinion better because I'm too much close to the lens. Do you understand my point?
Of course. Lukan, please.
I can comment exactly on the Acrisoft. It cannot be sutured with any suture because the haptics are fragile and then they will open. The only single piece hydrophobic IOL which can be sutured with Gore-Tex is MX60 and Vista from B&L. But I think this is a USA trend, the Gore-Tex sutures, and I also don't like that because we don't have them here available and we do well with pro-lens sutures.
Another question for you, Athanasios, from our audience. Do you recommend doing periphery shaving in these cases?
Well, yes, if I can. I do scleral depression and I do peripheral shaving because sometimes there are little holes or you create some holes for the traction you have. Remember that if you have drop nucleus, drop lenses and anything, there's also an inflammation, an irritation of that. And you got a posterior segment that is full of things and you want to remove them. So you have, first of all, to check, as you usually do, for a little hole or if you do something. So this is the best way of doing it. You don't want anything to be grasping vitreous and be moved around the eye because under the iris, you cannot see the haptics when they move around, where they're grasping or what they're doing. That's why I'm doing Kenacort, whatever you call it. I'm using it a lot. So that's the only way to understand if you remove everything. Even the anterior chamber and posterior chamber, I wash with Kenalog in order to know that I don't have any vitreous. I'm a vitreous against guy. I don't like vitreous anywhere when I remove anything in the eye. I think it's very, very dangerous. That's why I don't care about fishing. I don't like people when they go in a vitreous cavity and try to grasp something to move it out without removing the vitreous first. That's why I don't like anterior chamber or things that you don't have vitrectomy. I'm using sclerotomies to put the lens inside in order to have a complete vitrectomy beforehand. I don't like things that can be put without vitrectomy. Only the mobility of what you're doing inside the eye can produce retina detachment. And I think I'm a very good fan of Carlevale lenses because that's, in my idea, that's the only thing, but you need to do vitrectomy in these cases. Without vitrectomy, I wouldn't do anything. Probably it's my job. Don't know.
Okay, thank you. So you just mentioned our next speaker, the trendy guy at the moment. Please, Carlo Carlevale. Andiamo. Grazie.
Thank you, Gustavo. So let's go ahead. This kind of lens comes from my idea, basically. This is my disclosure. On 2012, I had an idea. Why don't put a T-shaped plug on a closed optic of a simple intraocular lens? And since from the beginning, the lens worked nicely. So within 2 years, I have presented to the European Congress of Cataract and Refractive Surgery the first report of the first 9 patients. In collaboration with an Italian company, Soleco IOL division, that's the final model. There are many features inside that are interesting. Of course, the idea is this plug. It's just a T-shaped plug that once it's pulled towards the thickness of the sclera and goes on the other side, opens like an harpoon and stabilizes the lens to the ciliary sulcus without stitches. One important thing are these notches. Can you see these notches? These notches allow the lens to be adapted to different diameter of ciliary sulcus, so the distance between the optic disc and the cornea will be unchanged. So this lens has the LP, effective lens position, does not change. So this lens has a very good refractive predictability. One more thing you should notice, that the loop of this lens is very big. It's like a wing. And this loop stabilizes the lens inside the sulcus, so this lens cannot tilt along the axis that connects the two plaques. This lens has a very good three-dimensional stability. This is a very good paper from Takeshi Suture that shows all the sizes of the sclera close by the ciliary sulcus. The plaque must be buried properly in the sclera, and the thickness will be between 1.5 to 2.48 millimeters. That's the key point of this procedure, this picture. In the beginning, I started with the surgical technique, the basic. So I started with some scleral flaps, opposite, 3.5 by 3.5, then perforating the bed of the scleral flap with a 23 or 20 gauge needle. It is mandatory to have a curve or a curved forceps, because if you don't have a curved forceps, in a deep set eye or in a big nose patient, you will be in trouble. So you will not be able to engage properly the plaque, the T-shaped plaque. Video. Two scleral flaps. The forceps is inside. The forceps holds the lens. All the lens can be injected in the eye. At the same time, the forceps externalize the T-shaped plaque that opens on the sclera. That's it. The same thing we have to do with the trailing optic. The forceps engage the optics and the plaque and externalize it. Practically, the lens is fixated to the sulcus without any help of stitches. Special recommendation: mandatory to curve teeth or without teeth microcoaxial forceps. Always try the forceps in the scleral hole before inserting the IOL. Always engage the plaque before releasing all the lens in the anterior chamber. Otherwise, you may drop the lens in the vitreous. Always protect all the plaque with a good big scleral flap. Suture carefully the conjunctiva. These were my results: no plaque erosion, scleral necrosis, rupture, or dislocation of the implant. Here, there is a UBM that shows how the plaque is buried in the sclera. That's the drawing, and this is an OCT, and these are photos slit lamp, no sign of decubitation. This shows the dimensional stability, but I changed the method. To sculpt a flap, it's longer, so I've changed the method. I made two radial cutting on the sclera, and then with the crescent, I'm delaminating two pockets. I'm going to the video. I have to run because there are many videos. Radial cutting, two small pockets, perforation on the bottom of the cutting at 1.5 millimeter from the limbus. Once the forceps engages the plaque, then you can insert all the lens. Because if you don't hold the lens will fall down anyway. Now the forceps externalize the T-shaped plaque on the sclera. Temporarily, it will be on the sclera. Same thing with the trailing optic. Now with the forceps, all the two sides of the plaque, they are buried. They are we have to put in the small pocket. I advise you now a suture. Otherwise, sometimes the plaque can jump up from the sclera. So I suture the sclera now. This is a photo. You can see the plaque, the radial cutting, the plaque, and this is a OCT that shows how is this one and this one, how is the plaque buried in the sclera. Tip and tricks. These are pig eye simulation. You can see how the forceps pulls the T-shape, and the shape bends like an arrow, is pulled through the thickness of the sclera, is pulled on the thickness of the sclera. You see it bends like as an arrow. And once is it on the other side, opens and stabilizes, fixates the lens to the sulcus without help of any stitches. Other tricks is important. To make a hole in the sclera, ideal is a needle, not the scleroton, for my opinion. Why? Because make a round hole, we want a round hole. If you use the scleroton, you will have a slit-shaped hole. Always try the forceps, and then you can start the insertion of the lens. One more thing, which is important. The lens is very big lens. There are big optics. So the surgeon should blow the lens in the cartridge, because you have to expect that any part of the lens is perfectly in the cartridge. Otherwise, you can catch some part of the loop between the cartridge and the rubber piston, and you can insert the lens in the eye, which is already damaged. Complications. This is a funny complication. I started to insert the lens. I engaged the plug in the proper way, you see. When I started to insert the lens, I realized that my cartridge was outside the globe. You see, I have pulled the plug, but there was no damage because the lens is very elastic. If I would have used a 3-piece lens, certainly I would have damaged it. This is not proper blade. This is a 1.2 millimeter blade, and the surgeon on the way back enlarges even more the incision. This is a mistake. What will happen? Will happen that the plug will have chance to slip back in the vitreous. But the classical complication of this technique is this one. When the surgeon holds not the plug, you see, but just a part of the loop, what will happen? Once the forceps externalize the part of the lens, outside the globe will appear just a jelly cluster of loops. What to do in this case? Now the harpoon is open on the other side, so it's difficult to pull out the harpoon. So, or put everything inside, first chance, and then try to engage again the harpoon in the proper way, or just to bury deep in the sclera this part of loop and stitching it. So a little part of the loop will be buried in the sclera and will hold the optic. That's it. Then there is another chance. The colleague Stylianos Skandarakis presented this video, and what he did, he patiently started with the forceps. He had the same complication, and started with 2 instruments to pull one side and other side till to externalize the plug. Of course, if you have a big hole, you just can stitch it. This is the last video. It was a very strange complication happens to me. In this case, of course, Athanasios Nikolakopulos does not agree, I know. What I've done, this was a luxation of a bag together with the lens. I put viscoelastic, I inserted the lens between the vitreous and the already luxated lens, but I made a mistake. I didn't hold properly the plug, so the forceps went outside without a plug. So this is a tricky situation. The plug is here, behind the root of the iris. So what to do now? Panic. What to do? What I did, I started to fixate at least the second loop. And the visibility was good, so it was very easy to do that. Sorry for exceeding my time, but it will be another 1 minute. So at least one of the 2 loops are externalized, are safe. So the lens will not fall in the vitreous, first. Second, I have removed the lens. Now I put Midriatic. I put Midriatic inside because still the other loop is here, somewhere here. With the Sinski, I started to move the lens. So I could see the plaque. With the forceps, I have engaged the T-shaped plaque of the trailing haptic, and I have fixated the lens to the sclera. In this case, I have removed one lens, and I have implanted a scleral fixation lens without touching the vitreous, despite the opinion of Athanasios. What is the future? What is the future? We already know is the finish. Okay, we already know that proline and even the plaque just covered from the conjunctiva will create decubitation within 1.5 and 2 years. But our experience knows that some material can stay just covered from the conjunctiva without any decubitation. If we will find some shape and some material that can stay just on the sclera, just covered from the conjunctiva, we can make simpler the scleral fixation procedure. Thank you for your attention. I hope to see you all in Salonico in October.
Bravo, Carlo. Very, very good. I had lots of questions, and your presentation answered almost all of them. We have one of the audience. Do you do vitrectomy before?
Of course, yes. I showed you one exception, but in the majority of the case, you have to do. Yes, of course. At least you have to remove all the vitreous in front of your IOL.
Very good. Athanasios, you had a question?
Yes, first of all, I would like to congratulate Carlos for showing his technique with his name and showing all the complications. That's very, very unusual if you want to promote your lens. And thank you for showing us what can happen. The second thing, I have an experience with, we call it myself technique, that I'm stabbing to do an endosclera, I'm stabbing 2 millimeters from the cornea, both sides, 180 degrees, and I'm taking out the haptics outside, and I leave them actually between and I'm suturing only the sclera. I'm not suturing the haptics, and I just make a small pocket at the end of it. And we had 150 cases where the haptic was actually free on the surface of the sclera, and nothing happened. And it was just a 3-piece lens. So we did a test. Last year in TVRS, we had 40 lenses by Carlevale lenses. By Purnaras, he brought them from Switzerland, where they love it. And we tried to put it without making anything. And we found out that if you put one haptic outside, you usually miss the other haptic because they go down. So to hold one haptic is not enough. When you put it out, the rest of the lens is very heavy and it goes directly down because it's flexible. And then if you try to get it and take it out, you have to go deep inside the eye. So no vitrectomy, that's why I say you have to go deep and you have to catch it from a certain position. You cannot catch it. But they are flexible, and we always have a couple of things when you put it so strongly or you want to take it out through a small hole, you break it or you bent it. But it's very elastic, and I love this elasticity that they have. They can suffer a lot of traction without cutting or bending or something like that. But I would think in the future that you make a radial cut, you make a big radial cut, not a small one, because you just need an opening to get out very, very easily, and then you leave it there. You put the conjunctiva on top, and you suture only the sclera, and I don't think you need, from our experience, now clinical experience, I want to ask everybody else about that, you don't need to cover it with sclera, because that's the ugliest thing that I've seen. A lot of blood, a lot of things, is not so nice when you see it.
Very good. Lukan, you had a question.
I don't think you need a flap.
Listen, I mean, I think at moment, the majority of my experience, there are some people that have operated many cases in Ivory Coast. They have a lot of decubitation of the plaque. because the plug is bulging in a place where the conjunctiva is thinner and in a place where the eyelid presses continuously on the area. You understand? I mean, if you have a valve tube, usually they are deep in the fornix, but in this case, you have to stay around 1.5 to 2 millimeters from the limbus. So that area is too much delicate. So at the moment, I advise you don't put just on the conjunctiva. If the experience will tell you in the future if you are right or not, or if you can put it only in the conjunctiva or not. Of course, if you can put just on the covered with the conjunctiva, the procedure will be even quicker, even simpler, and less traumatic for the eye. But this is just an experience, and the future will tell us.
Lukan, please.
I was lucky enough to implant this lens on a human eye, and I'm really happy with it. Here, the lens is really flexible. I want to ask why now on the pipeline there is a hydrophobic version, and why you will make a colored or ancture of the lens, because the visibility, and the second, why hydrophobic, because you plan to change the shape of the ancture in order to be more forgiving for the conjunctiva.
This is another option. At the moment, the biocompatibility is perfect, and I mean. What is sure that you want to give a product that works, that does not have any risk. You understand my point? You can implant as you like, but I mean, you should understand me. In the beginning, on 2012, I started to put some material in the sclera that nobody else has done it before me. So I made a step-by-step procedure. So no problem, go ahead, one more patient. No problem, one more patient. I mean, it was a totally new procedure. Now, after 8 years, we can tell you something more. But anyway, we have to be prudent, and we have to change the step by step. We cannot move directly to a different other idea. We need to experiment. We need to try for our mistake. We need to learn for our mistake and for our complication.
Absolutely. Ahmed, I want your comments on this lens. Do you have it in Canada? What do you think about it? You are a creative man, please.
Oh, I think it's very clever. I mean, congratulations, Carlo. I really look forward to getting hold of this lens. In Canada, we don't have access for this, so I have to come back and visit Italy and sneak some over in my suitcase. But congratulations. I think that some surgeons do have reservation about hydrophilic material. I realize that there's different controversies. I think it's a good idea for those surgeons and patients who prefer to use a hydrophobic material. So I think this is probably a reasonable approach to do this, because I know this is a concern in terms of pacification, for example. So I think it makes sense. I think, and I understand you're making a different material as well.
Yes, I mean, there is an FDA. We are starting. The company is starting for an FDA in America at the moment, the procedure. But I mean, there are some prototype of the hydrophobic. But the thing is that the material will change, will be more stiff, will be more rigid, and basically, we don't have the problem of the PCO pacification in this case. So I mean, we have only the problem on the absorption of the material with the hydrophobic. If you have a detachment, you have to make a dye in the eye. That's the only problem. For the PCO pacification, there is no problem because they don't have capsule usually.
Yeah, no, I meant calcification, not PCO, not posterior pacification, but the material pacification, like calcification, which is something that we know we observe in hydrophilic lenses. I know it's not common, and I know it's it's a debate, but as you said, it can happen. It can happen certainly with vitrectomies and air fluid exchange and things like this. So I think that's one reason why some surgeons are a bit worried about hydrophilic material for the reasons of calcification.
That's true. I mean, but already the hydrophobic. The problem of the hydrophobic that you can maneuver is more difficult, a little more difficult to maneuver the lens. This lens, like it is, the connection between the material and the shape at the moment looks extremely good, perfect. We will see now what will happen changing with the hydrophobic.
Well, good luck. I do look
forward
to on it.
Yeah, thank you.
On either material.
Yeah, thank you.
About injecting it in the anterior chamber. Injecting the lens in the anterior chamber, and then go with two hooks and take one haptic, put it back, take it out, so the other one will stay above the iris. So you go back and take it the same way we do with a three-piece lens when we're going to get it behind it. It's a safer procedure because you don't have the lens possibility to go down when you put it.
I know you had this problem. With the hook, with the Sinski hook, I try to pull it and to lift the lens like a flag at the iris plane. I use a Sinski hook.
Yeah. And
Carlos, Matteo, last question for you, please, because we are late with this.
Congratulations, Carlo. Wonderful lens. I tried and it's really easy to manage. Two questions. Do you prefer any meridian to place the lens? Inferior to superior or 3 to 9? And the second thing is, you recommended in some videos or whatever I saw you to don't do diathermy to the sclera, just to avoid the sclera to be reduced and to scar. Then a comment of this, position and diathermy on the sclera.
Very good question, both. First one, I try to avoid the vertical and horizontal meridian for the ciliary artery. So I'm a little bit obliquous, supranasal or supratemporal first. Then I study the face of the patient. I study if there are some difficulties. I have to feel comfortable during the cutting the sclera. Usually I use inferotemporal and supratemporal position because I'm temporal to the patient first. Second, I don't cauterize the sclera. I just wait that the bleeding will reduce because otherwise you will have a weak sclera. You may have some necrosis, or the chance of a plug jumping from the sclera in front of it is more because the scar retraction can pull upwards the plug itself.
Very good. Thank you, guys. Let's go ahead. The next one is this humble moderator. Let's share my screen.
One second, please. PowerPoint. Perfect. Here. Now, share screen here. Perfect. Can you see it?
Yes.
Perfect. So before starting, I would like to honor my residency professor who passed away last week. He was almost in his 90s and he finished his life working. He was a great man. He was one of the pioneers in cataract surgery here in Brazil. He was my father's professor, my professor, and my brother's professor. So may he rest in peace, Professor Flávio Rezende Dias. Very good. So I'm going to talk about the marionette suture technique for tilted IOLs. I would like to thank Professor Athanasios for giving Lukan Mishev and myself to organize this event. So far, I think we are doing great. I hope our audience is liking it as well. So, people have talked a lot about secondary IOL implantation. How do you plan it? Please don't go into it before thinking, before using your brain, okay? you have to see which are the causes. It was a trauma. Are you going to exchange because the lens is opacified? It was a cataract surgery complication. Check if there is capsular support. Where are you going to put it? Are you going to fixate in the sclera, which is now the new tendency? We saw lots of many cases where people fixated them in the iris. I personally don't like to do iris fixation. Okay, and what is the type of IOL that you have access, or which one would you like to use? So I don't need to talk very much about the Yemeni actually, how he says technique. But I just mentioned it here because the marionette suture is inspired. It's a hybrid technique between the Yemeni and the safety basket, which was described by Samuel Maskett 7 years ago, where he sutures like a hashtag, like a net, in order to reposition the IOL or to do a secondary implantation. He does like a bed for the IOL. So here comes the issue. We have this tilted IOL, and we have two options to put it in place. To change it, which is an idea I don't like to open eyes very much, and I think that patients don't like it as well. And the thing is, we can put it down, or we can bring it, lift it. The thing is, if you want to bring it down, we should tie an elephant on it, and it is a complicated situation. So we, like Lukan said before, it was an emergency. It was something that we improvised. I thought about using strings like a marionette. In a way, we can control this Muppet, like we have here, Geppetto and Pinocchio, to honor our Italian friends. And how could we use these strings also to control the IOL position, to have it the better ELP? So the idea here is to pass a Prolene 10 zeros, under the IOL in order to lift it and to put it back in its original position. Here comes the thing. Let's play it. Can you see? So I have a piece under. In this case, there was no capsular support. Okay. So there is no chances that I can bring or reposition the single piece IOL in its position. So I'll forward the video. I lift it. I bring it to the anterior chamber, and this was done in a public hospital in Brazil where we don't have foldable 3 pieces IOL. So in this case, what should I do? I'm obliged to open the cornea. I take the first IOL out, and I'm gonna do a Yemeni scleral fixation. So here I do it with a 25 gauge needle. I feel more comfortable, and on the same time, I don't have the 27 with thin walls. I dock it. Always check if the haptics can dock perfectly to don't have accidents. I bring it out, and here I did a mistake. You're gonna see the complication. I didn't burn it enough to make the flange, so I pass it on the other side. And when I try to dock it, I deform the haptic because PMMA can deform it, it can be bent. I was a little bit rough when I was doing my secondary implantation. You can see that the IOL is already turned. It spins, actually. So here I do the flange with no problems, but look at the other side, the flange is out. So I cut it, I have already one haptic band, and I reinsert it. Now I do it more properly, but one haptic is shorter than the other haptic. So here I bring it out, I gently make the flange now more wisely. I put in position, but look here, I'll give a pause so everyone can see how the light reflects. It's on the edge of the IOL, and you can see that it is lifted because you can see the edge coming up. So here I have the technique in slow motion, so in order that everyone can see it, I pass a straight needle with 10-0 Prolene. I dock it at the other side with the insulin needle, the 25 gauge. It is perfectly docked under the needle. And what I'm gonna do, what is the plan here, is to do a double arm, just like the suture technique. First I called it was the half masket technique, because we are going to pass it 90 degrees from the haptics. So It's an opposite force that will try to bring the IOL up. I measure again. I always recommend to do it very symmetric, 180 degrees, because if you don't do it symmetric, and that was my idea at the beginning, you're gonna have problems. So I pass it, I'll try to dock it again on the other side, same thing, just with opposite hand, with the hands with opposite instruments, and you can already see the reflex of the IOL, which is already a little bit more centered because I'm pushing it with the needle. That's one thing you have to consider when you do it, which is the position you are going to pass the sutures. Now you're gonna see very gently that the reflex of the IOL is changing. Look how the reflex is coming to the center and that the IOL is shining. So I'm sure that I'm changing the IOL position, looking for the best ELP. Once I have done it, I close the suture, and here's a secret: don't do it too much, otherwise you're gonna provoke an astigmatism. So the same day I created this technique, I received a WhatsApp message between one surgery and another, which I have another patient with a bent IOL, with a bent haptic, which had done a Yemeni as well, but it wasn't with me. And the patient was really, really angry. So I just had the idea, and sometimes you have to be lucky, just tell him, please bring him up, because it's gonna be a 10-minute procedure, and I'm gonna repeat the same thing. I asked for the keratometry. It wasn't a big deal. And here you can see I have the 2 stitches under the IOL, very well passed. I corrected, and the final refraction was -2. So probably this was one of the luckiest moments in my life. The patient loves me now because she can read without glasses. Okay. So this is another thing where you can use the half masket or the marionette technique when you don't have much capsular support and you have an IOL inside the eye. So you don't need to take it out in order to protect the endothelium. You just pass it, and you are going to increase the support with the 10-0 Prolim. I just have 10-0. I would recommend 9-0. Another study which we found here that Lukan Mishev gently sent to me. It was compared PMMA, polypropylene, and PVDF, polyvinyl, which just Zeiss in Europe has, PVDF haptics, which is the best one nowadays because it's the most flexible. The other PMMA, it's out of question, and the other haptics are not the best we have in the market nowadays. The take-home messages for the marionette technique. I strongly recommend doing a posterior vitrectomy. Otherwise, you might have vitreous traction. I don't dissect the conjunctiva because in less than 10 days, you're gonna have the epithelial cells covering the stitches because it makes an erosion on the sclera, so on the conjunctiva, sorry, so they will be covered. It's a very simple and fast technique to correct the tilt of when you have a tilted IOL. But the perfect scenario, it's not for everyone, it's not my situation. If you have an aura adapted to the microscope, you can control the suture. Of course, nowadays it's easier if you do the myopic shift with the Yemeni technique, but sometimes you can do it or you're not able to change the IOL. So that's it, my friends. Thank you so much for your attention. Go ahead, Lukan.
I think Ike has something to say about that because I saw exactly the opposite case from his Ike. Can you comment on that?
The opposite, I'm curious.
The opposite, yes.
Well, yeah, I know. I think it's a very clever approach, and we've had cases where we have scleral fixated lenses, for example, that may be fixated a bit anterior, and they cause chafing or optic capture, and so the same idea can be used to place on top of the lens to move the lens posterior. And away from the iris. I presented a case of a monocular patient who was a high myope, and despite a PI, still developed iris chafing and optic capture and erythema. And rather than take the lens out, we simply just put the mattress suture, as you described. I used 9-Prolene in that case, and I tighten it up. And intraoperative OCT you can use to assess the distance, and it can work out well. So I think either approach is great. I think it's a very clever approach. So. Congratulations to you as well.
Oh, thank you, my friend. Actually, I'm glad to hear that because we had a few cases about it, and after I had a better idea from what I was doing, I was started to change positions because one string can be higher than the other, and you start playing with it the way you prefer.
Mm-hmm.
Very good. Yes?
Only a comment. You mentioned about the composition of the optics. It's
Yes.
not only that, this is clear, but it's not only that. Another important thing that some lenses that are PMMA in the optics, the juncture with the optical part is not that strong. Then perhaps you don't break the optics, but the juncture with the optic part is not that strong. Then they break there. Then I think you have to consider when you manage this kind of.
Thank you for mentioning, and you brought me very bad remembers in my mind.
For me.
Okay, thank you so much. Next one, Didier Ducournau, please.
Okay. So, okay, so it's a very old 6-minute video that I presented the first time 20 years ago in Halkidiki, close to Thessaloniki. So it's a kind of return back with Athanasios. It's a very simple video, very simple technique, easy to perform, that avoid 10 to 20% retinol detachment that happen after PFCL injection, because the IOL does never stay on the top of the bar. I would like to present to you how we can easily pick up a dislocated IOL and place it in the anterior chamber. First step to do, whether we decide to remove or fix it. I will start showing you how to do with a one-piece soft monoblock IOL. In those cases, I decide to pick up the IOL with the Faco tip, controlling the aspiration flow with the foot pedal. You then only have to return the tip and push the IOL through the pupilla. It's very easy, as the closed loop haptics offer no risk of injuring the peripheral retina or the corpus ciliary, and the small size of the IOL allows going through the pupilla. This is another example, but in that case, the capsular Rhexis is very small. I choose them to help myself with a 30 gauge needle entered at 3 millimeters from the limbus. Much more complicated is to remove a 3-pieces IOL or a monoblock IOL with open haptics. When you take the proximal haptic, which is the closest one to the sclerotomy, you have a serious problem when putting the lens in the anterior chamber. The haptic really spreads out and the IOL becomes larger than the pupilla. A simulation from the side makes it easier to understand. Instead of selecting the proximal haptic, you have to choose to pick up the distal one. The acute angle between the IOL and the forceps will enable the proximal haptic to enter the anterior chamber first. The haptic will deform, allowing the remaining IOL to go through. In practice,
practice, several situations can be observed. First of all, the IOL is often vertically placed against the retina at 6 o'clock. In this case, it is really easy to pick up the distal haptic, the inferior one. The IOL will be spontaneously placed in the right position. Secondly, if it is placed in a more posterior position, after the distal haptic has been taken, you will have to turn the forceps in order to present the IOL correctly. For this, the choice of forceps is really important. As far as I'm concerned, I don't like using sugar forceps. I greatly prefer forceps with a lever to close the jaws and with a wheel to make the tip turn. When the lever is closed, there is no risk of losing the IOL. You will have just to turn the wheel in order to put the IOL in the right position. Of course, this is when working with an operating slit lamp, which leaves the operator's left hand free. Unfortunately, most of the time, the lens is horizontal on the posterior fundus. It is then difficult to obtain an acute angle between the forceps and the lens. However, a 30-gauge needle will facilitate the operation. The needle will allow us to take an acute angle so as to get an appropriate haptic in the right position. Now let's go over each step of the procedure again. Do not choose the proximal haptic. Prefer the distal one. Pick up the haptic by closing the lever. Pick it up from the retinal surface. Turn the wheel. And then, since the angle is not acute, use a 30-gauge needle entered at 3 millimeters from the limbus in order to orientate the lens. Pass the proximal haptic through the pupilla and then pass the remaining lens.
So that's it. You see, it's a very simple technique, but it's very old. So, but I am very old, so it's normal. Thank you.
Very, very good and elegant, Didier. Really, really nice.
Thank you.
Yes, Athanasios, let us know.
I would like to thank Didier for showing us that you need the other hand also, and you don't have it to hold the light because you already had the slit lamp in his hand. But usually not many people have this technique, the slit lamp, but it's so that by manually is the way to put it vertically. So that's the way to get it out. That's why I'm using two forceps to do that. And the other issue now in our age is that we need to have the haptics to be safe and corrected, not to bend or to break. And I would much rather, and ask Didier for that, I would much rather hold it from the body of the lens, not from the haptics when I want to put it in the anterior chamber, because then I want to do it endosclera, putting the same lens at the back. I don't remove the lens if I can save the lens. And that's the whole thing. I mean, if you think that we should avoid the haptics, but only if necessary, use them and use the body of the lens. Thank you, Didier, for coming.
Thank you.
Lukan, any question about the technique? I know you like different stuff.
Just a comment that the technique is really clever, and the level of magnification and the detail which is achieved with the slit lamp and direct lens is unimaginable. Congratulations.
Thank you.
Matteo?
That's great. It seemed I was in Kalkidiki when he showed this idea. I was there, and I showed this amazing, he's an amazing brain, and always been a great surgeon, and, great idea, and, it's very useful today. Thank you, Didier. It was a great idea. Forlini, you wanted to say something?
I just said that actually it's great technique. I did many times, but actually, like Athanasios said, usually if I can take the optic instead of the haptic, I feel just more confident to not break in the haptic, especially for 3 pieces IOL. But Didier technique is, I think it's a classic. It's like a milestone.
I have to leave soon, but I wanted to thank you all for amazing presentations, great camaraderie, innovation. I learned from everybody. I'm just thrilled to be in this group, so thank you very much.
Ike, I want to invite you in October, if we do it end of October in Thessaloniki, when there's no Ramadan and we can eat free. Okay?
Well, thank you. It would be such an honor. So keep safe, and we'll see everybody soon. Thank you.
Thank you for being with us.
And keep that name, Mike. It suits you very well. Thank you. Bye-bye. Okay, let's go ahead. My good friend, my brother, Vladislav Dzinic from Serbia. The screen is yours.
Thank you, Gustavo. Just a second. Good evening to everyone from Serbia. My topic is sulcus implantation. I want to share with you 2 interesting cases where with the EOL subluxation, which we finished by repositioning and implanting a new lens at the leftovers of remnants of the capsular bag. The first case is a lady who presented at our clinic after a usual or standard ophthalmologic examination. She previously went for retinal detachment surgery with conventional one, so she had a scleral band, and the cataract surgery was performed a couple of months before, and everything was perfect until the ophthalmologist dilated the pupil, and she presented with secondary glaucoma and luxation of subluxation of the lens into the anterior chamber. We can see that there is a 3-piece IOL, which is prolapse, that the Rhexis, anterior Rhexis is very large. So what we aim is to, as we had a problem, that there was a retinal surgery already performed, we went for a vitrectomy. So the vitreous was very, very hazy. So we cleaned and can be seen easily. We completed vitrectomy, and then we enter into the anterior chamber with a corneal incision, put the viscoelastic inside, and just take one haptic and place it just behind the iris. We saw that we couldn't go for optic capture, then we went down and just checked the retina. We take out the vitreous above the previous retinal rupture. We did additional laser and finished with 360-degree laser just for protection posterior to the scleral band, and put the SA6. This is another case, interesting, a male patient who went to a cataract surgery and everything was perfect until he went for YAG laser because of the ossification of the capsule. We saw luxated intraocular lens into the inferior nasal part. So we decided for sure to go for a complete vitrectomy. We put the infusion on and just put the one trocar in order to finish and to take out the vitreous from the posterior part of the capsule and the IOL. After that, we took the lens and take it out, the lens actually behaved very, very strangely. Like it was mentioned, you will see now the haptics, the distal haptic was like rolled and inside. We could not actually find out whether this first lens was implanted in the bag and then sank or luxated to the inferior nozzle, or it was just it put on the remnants of the anterior capsule, outside the bag. So we took out the lens. We use the technique you'll see in a moment. We split or cut optic part of the lens, the 3D quarters of the optic, and took the lens out. The first idea for the surgery for this patient was to perform complete vitrectomy and to clean up everything and to put the scleral fixated IOL. But after removing this one, we inspected the peripheral, the leftovers of capsular bag. And as we already planned to go for vitrectomy, we thought that, okay, let's try to put the three-piece IOL onto the leftovers of the capsular bag complex, and if something would happen to it, for sure go down and take it out and do the Yemeni technique. You can see that at this point that actually this lens also went a little bit nasally, but we took the forceps and tried to orientate the haptics in a manner that they stand between 6 and 9 o'clock and 12 and 3 o'clock. We put the suture, corneal scleral suture, and after that we went down to see if something happens with the retina, to do the inspection. After cleaning the complete vitreous, you can see we widened the posterior part of the capsule and the lens is staying stable. We've performed complete vitrectomy. We did peripheral shaving with indentation. The lens cap was in the position, so we decided, okay, we will live like that. We put the air as a tamponade agent and one air bubble into the anterior chamber. So the lens keeps stable for 2 years. I want to thank you and invite you to TVRS 10th years, the last week of October. Thank you.
Very good, Vlad. Very, very good. Nice cases. Let me make you a question. You
Yes.
said you have a posterior capsule opacification.
Yes.
Many people do the YAG laser before the vitrectomy, and other people prefer doing the capsulectomy. What do you prefer?
I prefer it. I mean, it depends, but I prefer to do during vitrectomy to remove the capsule. But it can be tricky because when you switch to do the fluid air exchange, it can be hazy. So sometimes you need to put a little bit of and clean it. But usually I performed it during vitrectomy. I made the small cut of the posterior capsule.
Lukan, you had a question.
Vladislav, in your last case, you
Yes.
You didn't do a peripheral iridotomy, and you used air in the eye and in the AC. From our colleagues which are doing DMEC surgeries, they always do a iridotomy when they leave an air bubble in the AC.
I usually leave the small air bubble into the AC, especially, but nothing happened. I didn't find any kind of problems without performing the iridotomy.
Mm-hmm. Okay.
No, depending, and it doesn't matter if I put the air behind or up. I mean, the tamponade with the air. So I didn't find any complication, any secondary glaucoma or angle closure.
Well, if you have doing a good vitrectomy, and if you have to keep the lens at the back because you don't want to have any leakage, it's the old custom when you did cataract in the old days without any viscoat, just to put a little bit of a gas there because it looks beautiful. and the first day. And now people don't prefer that because they like the patient to see the next day. But if you did the local anesthesia, it's okay. If you did a retrobulbar, you do, I'm sure, you don't need that. So you have to have this bubble. It's beautiful to see it, and you keep the anterior chamber full, and you don't have a flat anterior chamber the next day, or wrinkled, or anything like that. So it's a way of doing things. Incredible how many things I've seen today, and especially that I was really excited because I've been asked Matteo 6 or 7 times to join us in TVRS, and he was always busy at the time. So I think now with the coronavirus, he has to stay at home because he was always invited someplace else.
I was fishing him.
First time we have Matteo in TVRS, and also Didier is showing us that he was so far ahead that we have to go 20 years back to do the same things today. He was always in the future. So with Didier and Matteo, he's going back to the future again. And of course, I'm really proud of Forlini and Dzinic and Hüning and Mishev, because these people are the guys that they're much better than we are. And especially they have the technical knowledge to go further, because we're shoemakers. We know how to use our hands and our brain. They want to know how to use a video. They know how to produce something. They know how to. And now we had about 300 people at the beginning. That means that if you have a meeting with 300 people, it will be a full-packed audience that we never had before. So it's incredible what you did for us, and I hope we can do frequently, because I think the next step is going to be something like macular surgery or something like that, because the people would like to hear tips and tricks. They can get a book, they can get an internet, they go to see the videos. But I saw today 2 or 3 things that I never seen before, and I wouldn't recognize them when I see a video on the iTunes. And now you pointed out that Hüning something different. And I'm really proud also from Forlini, who is getting better and better all the time. And now it's my teacher instead of being his teacher. He just told me, don't do that, do that, don't do that, and do that. And of course, I would like to thank everybody for supporting this idea that we have. And you have to introduce to these people like Hüning and Mishev and all these young people that they are going to run this school, and this school is not going to die with me. So this is more important for me. It's a bit sentimental. There's nothing more beautiful than to see people that they were former student of the school 10 years ago, and now they are faculty and they are better than us, and they will keep doing it. Probably it's not going to be in Thessaloniki, because probably it's going to be Thessaloniki Vitrectomy Summer School in Brazil or in Serbia. I don't mind. I'm not a nationalist or not, even in Spain. But I'd like to thank also the memories, for Matteo and Didier, because we started together and we keep together, and it's, you're young as you're doing things in the future. We like to be in the future. We don't like to be in the past. And thanks for that fusion of young. And of course, the innovative things was our crazy things. Seeing an innovation, we get crazy about it. And that's why we like Carlevale lens. And we appreciate it so much being with us. And because it's something that it's new, it's fresh, and it has a lot of evolution in the middle. And I think it's not going to be complicated in the future. It's going to be everybody's use. And please send me a couple of lenses, because we don't have. I got 40 lenses for the wet lab, and I got none for the clinic. So
of course.
This is crazy. It's crazy.
I hope something is boiling in my pot, and I hope that in October I have 2 projects. I hope one to present you to present in your meeting in October for the first time. There are 2 things cooking in my pot. So I hope to present you something new, totally new, fully new again.
Okay, that's exciting all the time.
Carlo is a great Italian cook. So what he's boiling is
Cooker.
it's very interesting.
I'm a great Greek eater. Shall I? Food. Eating. Thank you, Hüning, for smiling with me. Huh?
I won't say any word, okay? I'm silent.
We don't have to say a word. They just have to look at us.
Yeah, that's it. That's enough.
So any other comments to conclude? I'm really happy. I'm looking forward to see you in October, if there is October. If there is October.
Oh, there will be so far as ever. Didier Ducournau, I'll start with you. Please, your last considerations before we leave the webinar.
No, I was impressed by this webinar. You know, I'm not so old, so I consider that the web solution is something great. I open myself a channel in YouTube. There is a playlist for macular surgery. I'm building now a playlist for retinal detachment. This is to say that I believe in this new possibility which is offered by this the system you offer, and so I congratulate you very much. Thank you very much for this work. Thank you.
Carlo Carlevale, please, your considerations.
So very interesting meeting. Opposite point of view. Gustavo, you asked me something, but I purposely kept silent because, I mean, basically what I think, I don't like to touch iris, and I'm starting to develop something else that should renovation of IOL, another model of IOL I'm drawing now fully, but anyway, I'm not touching the iris.
Thank you.
I feel suspicious iris. Okay. Thank you to everybody.
You are now my best friend since you don't like to touch the iris as well, okay, Carlo?
Yeah.
Il mio meglio amico.
Friends, but not touching.
I agree with
Not
you.
touching friends.
Carlos Matteo.
Okay, thank you guys. It was not supposed I have to be here, but you know, thank you very much. It's been an amazing webinar. Thank you for here with Didier and Athanasios. We are the same age, more or less. And congratulations for the young people, the strong people to do new things and new ideas. Thank you very much.
Oh, you were our surprise element. I'm glad that you joined us and that you accepted. He was a little bit shy, but I made some promises. Let's see if I can accomplish them.
This is his face. He's playing shy. He's never shy.
Actually he owes me one because I was doing an observership in Barcelona with him like 7 years ago, and there was a Russian patient, and he was worried because he could not communicate with her. Then he asks, who here can talk to the lady?
He started to speak with her.
And I had some phrases, and the patient was in love because she thought it was Carlos talking in Russian with her. He owes me that one, okay?
It was a blind patient.
Yeah, that's real.
Blind patient, yes.
No, it was beautiful. A macular hole, and she was 20/20 the next day. He's a genius.
Yeah, with the gas.
Vlada, please, your considerations.
Like it very much. I'm glad that to join you. The organization is perfect, and the topics and the people which would take part. I like it very much. I hope we will make something more in upcoming days and to keep it going until the October.
Thank you. Forlini?
Well, you know I like to touch the iris, so I hope we can stay friends, okay?
Depends on the invitation you give me.
Yeah.
Definitively, Matteo. Definitively.
Matteo, it's your turn, you know. Hüning and Mishev have done their job. Now it's your turn to do the next one.
Okay.
Wake up.
We'll help him.
Well,
Lukan Mishev.
You've been in webinars every week.
Every week.
Every week you're in a webinar. And people would think that you're much older than you look at, since you don't have any hair.
He's a playboy.
But
Lukan Mishev, your considerations, please.
Well, my idea was just to my idea would be one webinar with more people with a free discussion, no subject webinar. No subject. Tell me
let's develop it.
Your idea. Tell me what kind of food you like. Tell me, just a company of people that they like each other and fight against Irish touchers and Irish non-touchers and do something funny. Do something new.
Let us finish because people are leaving. Lukan, please, your considerations.
So I also like to touch things. It's also Iris, of course, but hopefully we will, yeah, we will stay friends. And with that said, me and Gustavo are available to assist Matteo on next webinar or something, some idea that he might develop. And I want to thank you because we all learn, and we, the younger one, tend to forget that the surgery doesn't start with us. So thank you for all the tips and tricks that you share, and we see that the surgery is an art that should be passed by generations. Thank you.
Thank you. Lukan said the same words I would say, that knowledge is something that it's constructed on the knowledge you had in the past. So it's like a house, a brick over brick. Thank you, everyone. This was a TVRS and Boris Cinema Productions. Thank you so much.
Honey, I got just a message just now from Yahia Salah. Yahia Salah is the best cataract surgeon I know to the Mediterranean area. He's an Egyptian excellent surgeon. And he said, excellent webinar, I'd like to be part of it next time. So don't forget that we have people who would like to participate, so make it bigger.
Oh, that's the best thing I think about that Corona brought to us is the Zoom webinars, because we dislocated the axis of the control. We have 100 webinars in 100 different languages, so it's a tsunami, it's not a wave. Thank you, everyone. Have a nice weekend.
Thank you.
Congratulations.
Bye.
Bye-bye, everybody.
Bye-bye.
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 Bye-bye.